My presentation is today for evolution of anesthesia in Pakistan. Anesthesia की evolution Pakistan में in medical fraternity is just like that, which I can say in one share. फसील शहर में पैदा किया है दर महीने. That is the effort of the anesthesiologist in the whole medical fraternity. That फसील शहर में पैदा किया है दर महीने, किसी भी बाब रियायत से मैं नहीं आया. तो सारी मेहनत एनेस्थेटिस्ट की है, एनेस्थेसियोलॉजिस्ट की है, जिन्होंने इस मुकाम बनाया है अपना इन द एवोल्यूशन. एंड आई विल क्विकली रन थ्रू द एवोल्यूशन ऑफ एनेस्थीसिया इन पाकिस्तान. Well, definition of anesthesia, again, the most friendly person who prevents the patient and saves him from the wrath of the surgeon who is just making a mess of my patient, and he looks after the patient. So he's the only person who is a real friend of the patient. Well, the process of evolution started with in this part of the world or in Pakistan with a factor that who is practicing anesthesia and again how it is being supported scientifically or industrially or financially, and that is the main part that any evolution will happen here. Now this is the person I am talking about. This is a he anesthetist. I cannot dare to present a she anesthetist like that. Horrible. That will be, I will be, मेरी बड़ी पिटाई हो जाएगी इधर. So it is a male anesthetist, and you can see that he has got 10 hands, he has got lot of eyes, he has got lot of ears, and he is working very hard. He has got very small stomach, hardly finds time for any food. He has got a huge big bladder because he can't go to the loo, that sort of thing. And this is the person I'm talking about, and the evolution of the specialty which an anesthesiologist is supposed to be. Of course, female anesthetists are most welcome, but I don't expect that sort of management by female colleague. They can do some of these jobs. There is no problem for that. And the journey of anesthetist started as an art, and this art converted into a science. The practice was primitive at one time, now it is very modern practice. The manpower was highly untrained. Anybody could give anesthesia. Now we have got a qualified and trained anesthetist. Regarding the transition and the changing role, again, now anesthetists are the peri-operative physicians. And regarding the quality, again, safety of the drugs and the monitoring has made it absolutely safe at this moment also. And regarding the equipment, I will show you the primitive equipments, but nowadays we have got a wonderful equipments which are absolutely safe and which can be used on for our patients. And these are the few pictures in which somebody is trying to give anesthesia to somebody, making a mess of all these things, and very primitive attitude, very primitive anesthesia machine. And I have practically worked 51 years before something like this machine, like that in a private hospital in Karachi. That was the thing, and again all these things are primitive machine. As you can see that these patients are being managed by somebody. And nowadays, we have got these modern machines which has got wonderful vaporizers, which are absolutely accurate and safe for our patients. So these are the things which we are managing, and this journey has happened in the last 50 years. I am practicing anesthesia in the last 51 years and 46 years in Pakistan. And I have seen all these machines being used as such. Regarding anesthesia, this scientific and documentation, anesthesia has been practiced since last about 200 years. And it has progressed. It has fast progress in the last 30 to 40 years only. And in Pakistan also in the last 30 to 40 years. In the early years, an anesthetist was an assistant to a surgeon. I have seen that. And Anybody could give anesthesia, anybody was asked anesthesia, and in Jinnah hospital I have seen the technicians giving anesthesia, in civil hospital also, that sort of terrible attitude, and they were given anesthesia. And that made realize that surgery cannot progress without a safe and competent anesthetist. And that has later on, in the last 30 to 40, 50 years, converted a specialty and anesthetist into a specialty of its own. We are so proud of it. Responsibility has come out, which was at one time nobody was responsible, no anesthetist was responsible. Now the anesthetist is responsible for perioperative management, postoperative management, perioperative management. He is a pain specialist. He is a professional person who is dispensing the whole anesthesia, and he is a research and development person also. And he is a trainer. He trains, he finds a replacement for himself. And that is the beauty of it. And that has made it realization that this is something, some specialty, and a surgery cannot progress without the anesthetist. So I can say very safely that development of surgery is dependent on development of anesthesia in our society. And of course, to reach this status, tremendous evolution has happened in the world, which I am a witness. Brigadier Salim Saab also a witness. Mehdi Mumtaz is also a witness that we have seen all this is right in front of our own eyes. And in Pakistan, this evolution I have very conveniently divided into 3 time zones. One is from Pakistan starting, that is 1948 to 76. Why 76? Because I happened to land in 1976 back to Pakistan. So I have taken that zone into that. Then from 1976 to 2005, again why 2005? Because I retired in 2005, 17 years before. And of course, a lot of things are happening after 2005 since I am retired. But of course, I am keeping an eye, and there are a lot of colleagues are here who are from that zone, and they are head of department. I can see Dr. Amin here. He is head of department in NICVD, and it just sounds like just yesterday's thing that he was a brilliant student of FCPS. Now he is heading a NICVD, and there are other colleagues here also. So from 1948 to 1976, regarding the anesthesia service, it was terrible, very primitive. And then it started developing. 1976, it was ether anesthesia in Karachi. I had to learn ether anesthesia. I had learned another mono anesthesia in England, like halothane and trichloroethylene, trilene. But again, here it was ether, and GA was a very difficult job. Bach gaya, mar gaya. People were ready for the death thing, and we were not responsible any for comorbid, something like that. And major surgeries were done with high mortality and morbidity. We are all witness to that. Regarding anesthesia equipment and medicines, it was primitive and basic machines. Perioperative ventilators were not available, a luxury in Pakistan again. And then we had only 4 to 5 drugs. 1 relaxant, 1 induction agent, that's it, and 1 inhalation agent. करना है काम करो वरना जाओ, और सर्जरी 8-8 घंटे की सर्जरी भी करानी है. Of course, BP monitor and pulse oximeter, they were not invented in the early stages at that time. Regarding the human resources, we were very short of it. Hardly any qualified. We had only few, less than 10 fellows in Pakistan. Again, and very small number, around 40 minor diploma holders. Otherwise, the whole burden was taken out by the technicians and all those characters which were roaming around, and anybody could give anesthesia to anybody, that sort of thing. And what was the scenario in UK and USA, the advanced countries? Again, it was in UK I'm talking about, it was mostly general anesthesia, regional were hardly used, epidural was there, better preoperative management and workup was there, post-operative care was was better, and there was ICU backup for our patients as such. Regarding the equipments, basic anesthesia machine was there, and which was not safe because the safety devices were not invented. Regarding the drugs and medicine, it was the same drugs medicine, thiopentone for induction, 1 or 2 muscle relaxants like Pavilon and tibocororine, something like that. And of course, manual monitoring was there because we did not have all these nice things known as pulse oximeter. Regarding the human resources, in UK at least and USA, there were more trained anesthetists, training was better, it was dedicated, and there were more people available in that specialty. Into the second time zone, 1977 to 2005, we saw the anesthesia development in leaps and bounds. It developed very, very fast, and then all kind of anesthesia was being given and used again, and we saw a very powerful development around the country, especially in tertiary care hospitals, and we were doing all the cases. You name the surgeon, transplants were done, kidney transplants and all these things, we were able to perform at that. Regarding anesthesia equipment, modern, safe anesthesia machines were available. They were procured, and we had exactly the same machine which was used in other parts of the world because, again, laws were there, and there was some sense in getting all these equipments and monitoring equipments. They started in 1985 during the first kidney transplant. I bought the first pulse oximeter for SIUT, and that was something very, very nice equipment as such. In Pakistan, during that period, the new drugs were available, new inhalational agents were available, and many anesthetic agents arrived. There were few muscle relaxants available, and of course, so many analgesics as a tool for an anesthetist. Regarding the human resources, trained and qualified anesthetists providing anesthesia, that was the good news, but in tertiary care hospitals. And CPSP started to produce these post-graduation. More than 1,200 FCPS, MCPS were produced annually, but they were distributed in the country, but they also disappeared in the different parts of the world. They started looking after the healthcare in UK and of course Middle East backyard, and we filled the vacancies in Middle East. Of course, the incentive of money was there, and the incentive of Makkah Medina was there, so of course nobody can blame that, and that was there, and I will not blame anybody as such. In UK and USA at that time, safe and acute anesthesia was available, and full range of monitors and all these latest equipment and good ICU services were available at that. And then coming after that, what happened after 2005 onwards, there was a great advancement. Big cities, now they have got all the modern anesthesia machine, ICUs, tertiary care hospitals all have got all these facilities. Organ transplant is being performed in all the province of Pakistan as such, and supportive intensive care unit, HDU, and step down is available. Again, good news for the patient that their survival has increased, and of course now there is nothing known as not fit for anesthesia. There is nothing known as 30-40 years before this term was used, कि fit nahi hai. And now we are very proud that all the patients are manageable. And of course, this journey began as from mono anesthesia, mono agent to other agent. And ether and chloroform survived for decades and decades. Then inhalational routes were used, and we were giving a limited anesthesia and limited surgery, and of course there was high mortality and morbidity as such. Then after ether, another mono agent came, which was halothane, and trichloroethylene. 1976, halothane was introduced in Karachi, in Civil Hospital Karachi. We introduced halothane, and we got rid of ether because every theater was smelly for general anesthesia and especially C-sections, something like that. So we used halothane, and of course trichloroethylene was here also, which was also in UK also. We have used trilene as such, and halothane here. And of course that was used with barbiturate, thiopentosodium, and this monoanesthesia, laparotomy was performed into a deep anesthesia, stage 3, plane 3, and without any muscle relaxant by my senior colleagues. And I used to wonder that how this surgeon is so satisfied with this monoanesthesia in the hospitals, Civil Hospital Karachi also, in some private hospital also. Then came the balanced anesthesia. And this is just a combination of few agents for different activities known as induction, maintenance, analgesia, anesthesia, amnesia, and muscle relaxants. And that was something great we had achieved. And this was goal-orientated, and perioperative checkup was there, monitoring of vital organs became a norm, and fluid balance got the importance. Before that, people were not as clear as that the status of fluid balance is very important for the patients. And of course, we entered into a phase of safe anesthesia. And now we moved further into a balanced and tailored anesthesia. And that is happening at this moment, that perioperative workup of comorbids are there. Perioperative physician's role is there. Anesthetist is the perioperative physician. Organ monitoring is there. We monitor all the organs individually nowadays instead of the patient as a total. All the organs are monitored, and specific surgical needs are fulfilled. सर्जनों के नखड़े भी उठा लेते हैं इस वक्त, क्योंकि that organ, that especially the neuro and other places also, which is a remarkable achievement. That organ is targeted. And of course, pain management is also very much targeted nowadays, that you don't have to bother rest of the body, treat the pain right at the place where it is happening, and look at the nociceptors and manage that. Brigadier Salim is there, and he has developed this specialty in a remarkable way in the last 40-50 years, which I am watching. And again, he is the boss of pain management, fortunately in part of the world. And now we have entered another stage, which is smart anesthesia. None of you, I challenge at this moment, that you have got that little Nokia in your pocket at this moment. Anybody who has got Nokia in his pocket, please raise your hand. Nobody. You don't have a pocket, but you haven't got Nokia. You have got all smartphones. Why? The call is coming, the call is going in all the cases. But you are not happy with the Nokia. I am not happy with the Nokia because सिर्फ call आती है, call जाती है, बाकी कुछ नहीं होता उसमें. There is no WhatsApp, there is no email, there is nothing. So same thing has happened in anesthesia also, that we have entered into a smart anesthesia phase. We have got a lot of apps nowadays. We have got a lot of activity with the different agents as such. We have got totally different tools nowadays. 50 years before, 40 years before, the agents which we were using, Mehdi Mumtaz was using, Salim Sahab was using, is obsolete. It is obsolete in UK also, it is obsolete here also. And we don't use that. That is a good news, and our patients are much, much better. And the anesthetist is smart because he is doing an outreach activity also. Perioperative role is there. There is more understanding of the comorbids. Now we manage the diabetic ketoacidosis and diabetic patient uncontrolled very smartly. 30 years before they used to die, or a lot of complications. So smart anesthesia is being managed there. And of course, we have got more new agents. New specific monitorings are there. As I have said earlier, specific organs are being monitored as such. And then we have got enhanced recovery. Who could ever imagine or develop this word? Enhanced recovery word has developed. And again, you can predict, just like a pilot, that he says that at 5 past 4, I will land on the runway. So the anesthetist says that the patient will wake up in 3 minutes time, or if you want it, we can have a 15 minutes time also. So it all depends what do you want it. And that is a remarkable management or enhanced recovery according to the wishes of the patient as such. So we have got more apps and apps at this moment also. Of course, all these things has happened, but there are a lot of pitfalls. Nothing to be said about it, but there is a pitfalls, and I can see here that these wonderful drugs are not used in all the places. Shame. It is only used in tertiary big hospitals. What happens 50 miles from the city, Lahore or Karachi or Peshawar? So that is something that we have got a two anesthesia. One in the big hospital, tertiary care hospital, well-equipped hospital, and the other anesthesia is at the periphery, and again, that is not acceptable as such. Regarding the trained person also, trained persons are available in the cities, periphery, they are not available. So there are a lot of 101 reasons for it. As the Director Health, she has just mentioned that this is the ground reality at this moment. And this is the pitfall, and there are these problems we are going to face as that. So now what is the way forward as such? So anesthetist has become a perioperative physician. That is very good news. Safe and accurate anesthesia services for all should be there. No demarcation here and there also, and more induction of young doctors. This hall is full of young doctors, and I am sure you want to be anesthetist. Please become an anesthetist. We are short of anesthetists, so all the young people who are sitting here, if you are becoming a anesthetist, good news, and I would beg you, request you to become an anesthetist, because this is one of the most wonderful specialty I ever know as such. New agents are coming after every few years. There is a good news also, and there are more monitoring and safety features have come. So please use that, and they are invasive and non-invasive as such, and we have got a lot of equipments which are waiting to be used as such. Integral monitoring is happening around, and it costs to the patient more, which of course I resent at that. Highly trained persons will be available, and they are available at this moment also. And there is more involvement in ICU. ICU is a wonderful place where the surgeon is happy that he dares to take the patient to the theater because there is intensive care available. And we are very happy that we can manage this patient into an intensive care unit. Doesn't matter if his different organs are either in failure or dysfunctioning. So again, that is one of the best news. And there are more and more outreach programs. Thank you very much for your attention.